really gives me a great pleasure to introduce Dr. Greg Walker. He's a good friend and one of the best operators I've seen around. So, Greg is going to talk to us about popliteal artery revascularization, angioplasty, atherectomy, or stenting, one of the probably most difficult area to work with. Greg?
Thank you so much, Amir. These are my disclosures. And I want to tell you that when I think about this, and I was happy to get this subject, I think of the popliteal artery as three different arteries, and it also matters to me whether the SFA is involved at the same time. Now, why do I think of this as three arteries? Well, we have three segments. First, we have the P1 segment. This starts where the SFA dives behind the adductor magnus, and it's an area of great motion. In many ways, it behaves like the SFA, except it is much more dynamic. It also serves as a source of graft touchdown as well as graft takeoff in certain cases of surgery. I then look at the P2 segment. This is the middle segment from which the geniculate collaterals arise. Now, these geniculate collaterals are very, very, very important. One, we may perforate trying to cross this section. Secondly, geniculate collaterals serve as the receiving collaterals when the area above is occluded, and they serve as the giving collaterals when the infrapopliteal segment is occluded. And then finally, we have the P3 segment, the very distal segment, and this divides, giving rise to the infrapopliteal vessels. And the reason I view this segment differently is there's profound size mismatch. Whenever we go from the popliteal to the anterior tibial or the tibioperoneal trunk, there's profound size mismatch. This is very important. In addition, fixing one of these may result in jailing others if a stent is used. So we have many challenges when we treat the popliteal artery. We have flexion points in the P1 segment, vessel elongation and shortening, which can really fracture stents, multiple geniculate vessels, which may serve as hugely important collaterals, size mismatch whenever we're dealing with P3. This entire segment is often prone to dense calcium, which may make truly expanding the vessel well. We must keep in mind these sites serve as future targets as well as origins of bypass grafts, which may be crucial. There have been historically incredibly high rates of restenosis with standard balloon angioplasty, and standard laser cut nitinol stents often kink, may fracture, and may have insufficient radial force to deal with treating this segment. All this disease is not created equal. We have to look at the length of the lesion, the degree of calcification, the vessel's size, very important, total occlusion versus a stenosis, the runoff vessel status, I think perhaps the most important issue of all. Limb salvage or claudication presentation, active thrombus, is it already a restenotic lesion? Is the location proximal or distal? And finally, will the patient be able to afford and will they take antiplatelet drugs after? Because there are many people who cannot and do not, and that plays a role. Now, we all know that we've got a big toolbox now. We have balloons, and we had originally just regular old balloons, but now we have long balloons, focal pressure balloons, cryo balloons, medicated balloons, angioslide, which is an aspirating balloon. We have chocolate balloon, which sort of fits into a new criteria somewhere between focal force as well as pressure relieving. We have stents, and these fall into balloon expandable, covered, medicated, and bare metal. We have self-expanding, covered, medicated, bare metal stents. In the future, we have bioabsorbable stents coming out. And we have all forms of atherectomy. All of these can and have been tried in this anatomy. Now, at present, there are no randomized controlled trials comparing various therapies to each other in specific disease subsets. So none of us can get up here and say, this is what you must do. But as experienced practitioners who deal with patients for a long time, we can at least give some ideas of where we've gotten into trouble before and give you some thoughts. So this is my popliteal artery treatment algorithm in the United States today. In P1 segment disease, I consider some atherectomy, not necessarily full atherectomy, followed by a specialty balloon. What I'm trying to do is I'm trying to avoid dissection. If short segment disease, I may balloon and consider a supera stent at this point in time if there's a dissection, because there's been some data published out of Germany that that stent has done fairly well in this area. There's some early data emerging that also the Zilver PTX may work pretty well in this area. We need more data there. If long segment disease, I do atherectomy and stenting if needed in the P1 segment. P2 segment is a little trickier. I do the same as above, but I'm very concerned about the long-term loss of geniculate collaterals with stenting. And I'm most concerned about this over my practice, not when the SFA is involved above, because they're typically collaterals getting around beforehand, but when the disease starts at the popliteal. In that situation, I really worry about these geniculate collaterals. And in the P3 segment, where size mismatch and therefore stenting is such an issue, I really want to avoid dissection. So I typically perform some form of atherectomy, enough to make the lesion dilate well, and then I perform prolonged balloon angioplasty. And I typically prefer specialty balloons raised at very low pressures for very long periods of time, because it is my goal in each of these cases to avoid stenting if I can and preserve future potential surgical options. Here's one such case of exactly what we worry about. This is a patient presenting with an ulcer on the foot. We see the popliteals occluded. We see this rise of collaterals coming out, so we cross this. We laser it. We balloon the area up top. We then go after this occluded tibioperineal trunk, and we end up with 3 nice vessels to the foot at the end of this case. Now, could you do this with other atherectomy? Of course you could. Of course you could. And, you know, I think it's which one you use is dependent upon the presentation. Do you think there's thrombus? How densely calcified this area is, and your level of expertise. I happen to like laser in this area because I think it has a little less embolic debris. Now, this is a problem I've mentioned about stenting behind the knee. When we first published, David Ali and I, our first big article, in which we created the stent fracture classification, mostly used now 1 through 4 in endovascular today, we got some hate mail when we published that, because people said, you're going to ruin the field. You're talking about stenting, stents actually fracturing, because it was the first big article on stent fractures. But we didn't include enough in that. We can see that often, even when we, by IVUS at rest with a straight leg, get a great result at the popliteal, when the leg bends, standard laser nitinol stents kink, and in fact, often kink to the point that there is no flow at all. Now, stent options needed for popliteal interventions are needed if we have dissections, which occur during the intervention. If there's popliteal disease contiguous with long SFA occlusions and we have to extend the stent area. At areas of popliteal reentry where we've used something like an Outback or a Pioneer to get back in. Some of the popliteal CTOs where we simply cannot get a big enough lumen. Restenosis after prior interventions, ultra-long disease, and of course, suboptimal results, which occasionally occur. Stents in this area have to be conformable. They have to be flexible because there's profound motion here. They have to be durable. We know that if this disease occurs and the stents fall apart and fracture, it's a problem. They have to have high radial strength because these areas tend to be calcified. We hope to not hurt the geniculate vessels. They have to work in calcific lesions, have to be fracture resistant, and in my opinion, most slotted tube nitinol stents do not meet these criteria. But one of the stents that has been used extensively in this application is Supera. And in Germany, this was used and published in a fairly large series by Dirk Scheiner. This is a very flexible stent with profound radial force. It has very little chronic outward force. It bends very well, and fractures really have not been reported. And here you see this stent placed in dense calcium. And here you see a bent leg result with that. The stent maintains its shape with bent leg, and the pictures to go with that in this dense calcium. So at present, there is no present consensus on what constitutes best interventional therapy in popliteal disease. We're all awaiting FDA approval of drug-eluting balloons and have just started to have drug-eluting peripheral stents. The only stent that has significant published popliteal data is Supera, and the results with this have absolutely mirrored their results in the SFA, which is atypical for stents in the popliteal. And I'm personally anxiously awaiting the Silver PTX results because there are some, at least preliminary reports, that it may also be effective in this area. In the interim, I personally perform some debulking, followed by low-pressure prolonged balloon inflation in an effort to avoid dissection. I tend to use focal force balloons with low-pressure prolonged inflation, as they have been shown to lessen the rates of dissection and to give a bigger initial lumen. We have no restenosis data, though. Thank you very much for your attention.
Dr. Walker, I have a question for you and Dr. Matarjame. What happens to a viabon in a popliteal artery? Sometimes you have to put it, let's say, for a aneurysm. What happens to the characteristics of a viabon in a popliteal artery?
Be honest with you, Jaafer, viabon in popliteal arteries has a very good patency rate. It's tolerate the kinking better than regular stents. The only downside to that, it may cause thrombosis if patient kneels for a very long time. That's why when I put them in popliteal arteries, I always tell the patient, if they do gardening or anything like that, don't kneel for a long time. And otherwise, they do very well. We put them for aneurysm. We put them for a lot of pseudoaneurysm that we had after atherectomies, and usually do very well.
I would absolutely agree with that. I do think they hold up well. They don't tend to fracture. They do cover collaterals, which may be an issue. They don't have great radial force. And so in cases where you have high viscoelastic recoil, they may not be fully open, and that could be potentially an issue in those cases. But I think in general, it's a pretty good stent. And again, I think we'll get more data there with it. And, I really look very differently at a long SFA occlusion that involves the popliteal versus an occlusion that just starts right at the popliteal. You've typically had a chance to develop other collaterals with those very, very high blockages that likewise involve it. When the blockage starts at the popliteal, I think it's a different animal.
Okay, let's move on. I'm the next speaker, and when Jaafer asked me talk about my worst disaster and greatest save, and he gave me 10 minutes, so I was thinking about, first of all, be very honest with you, I don't want to sound a little bit, and I really couldn't think of any disaster, to be honest with you. And so I thought maybe I'd just go ahead and show a very interesting case. Until about 2 weeks ago, I ran to this problem. So this is an actual fluoroscopy going on. Run that, please. This is an 80 years old female that I recanalized her occluded left common iliac artery in 2000. So that's about 14 years ago. And I put a kissing stents on both sides. Now she had claudication, both legs, and she had calcified stenosis of superficial femoral artery. So I was going to do contralateral to work on the SFA. I did the arteriogram, I put it with pigtail, and I used the pigtail, same pigtail that I do for angiogram, going cross, then take the pigtail out and put a sheath in. So I did that, I went crossed, and now I can take the pigtail out. If you look at this, I'm moving that, and it moves the entire aorta and iliac arteries. Now, question is, what to do now? Peter, you have any idea? Oh, Peter is not here. Any of you on the podium? Mark? I have a short 5 French sheath, a pigtail catheter, and it's the other side, and I cannot remove it. Right now, I took my regular J wire out, and I put a Amplats, very stiff wiring, thinking that that may straighten it out, and I can take it out. And when I pulled, it looks like I went through the strut of the stent in rather than going through the lumen of it. And I think the problem is probably there, that I cannot move it at all. See, the whole aorta and iliac arteries move with that. Because of calcification, you can see it how nicely. And I had no trouble going over the stents to the other side because the stents are not sticking up into aorta. They are level off with the common iliac arteries. And I think the problem was probably going on the right side to the strut.
Amir?
Yeah.
Wonder if you could snare the wire that's in the left groin and then introduce something like a Van Andel over that and bring it on up and see if by holding the wire taut on both sides.
Okay, that's one option.
If you could push it, if you could
went
push it
through
back.
my head, yes. Thinking about maybe I should puncture the left side and do that. Any other suggestion? Short of going to the left.
Let's get a gold tip M wire available. Let's get a...
Mark, would you push that down here?
So far, you've tried 2 wires, right? I think you still have wire options here. I wouldn't give up on the wire first. I would even try a Lundequist, you know, one of those very stiff coat hanger wires, and if you can get it across, I think you may be able to remove it. But I would not puncture unless I would have exhausted my wire issues.
Okay, we got a pressure
now,
line
the
here.
idea that Tom has is a good idea.
Second.
But I don't think the Van Andel alone is going to do it. I think if you're going to be snaring from the left side, you're going to have to try to advance a 6 French or maybe even a 5 French sheath. I think a 5 French Ansel sheath may be able to take it and try to, you know, pass it over to protect and then pull from the other side.
The problem is that I can advance it a little bit further down, but it still cannot go further than that. Even a puncture from the other side, I grab the catheter, I might not be able to pull it through.
Yeah, your problem is you're going to have the physics are against you here. You're pulling and it's straightening it out. I would absolutely stick the left common femoral. I would stick this wire into my sheath, pull it out. Left common femoral. Come back up with a small catheter like a 5 French, quick cross, push it backwards. Because what you're going to do now, in essence, it's the difference between rear-wheel drive and front-wheel drive, if you would with a car. You're
Yeah.
now going to be pushing as you slightly pull.
Can you stop the tape now? The problem is the catheter is really caught on
Good.
this
Let's take our wire
right
back.
over here. And regardless of what side
time
you
frame
go,
here, we should be good.
you have this problem right here. When I pull, you can see that.
So, let's
So,
do that. Let's
run
have the
it
bare
again,
wire, or
please.
not bare wire, the Viper ready. And, oh, we wanted the IVUS that too, huh? All right, so what we'll do is, this is good, because we'll have the Viper ready.
see
We
that
can do either
the-
one. We can use either Diamondback, or we can use,
Okay.
we can use,
So what I did,
Silverhawk.
See, Amir? Could
yeah,
you-
go
could-
ahead.
Could you stick on the other side and just come up with a small wire system and using this catheter as a guide, see if you could, I don't know if there would be enough room in that slot to slide something else through there and then try to dilate that, with the balloon
okay,
introduced from the
hold,
other side.
hold the tape, please.
If it's really
So Amir, you think you're in
calcified,
the right,
that's probably what we'll do.
Within the stent strut on the right,
So,
Yes.
rather than left.
Yeah, as I'm getting in, you see the chink right now? I think the problem is right there. Rather than going into
know.
the
I think
the
either
lumen
way,
of
we'll
the
either use
stent,
Turbohawk or Diamondback.
because this
We'll
is a
have to see.
bare stent, and I went from the side of it,
Pressures. We'll check it later.
because there is a chink in the artery right there.
I mean, the other option that you could do because of that would be come from above, I think, and bring a snare down into the left side with a softer wire that you have through that catheter, and then maybe just actually pull it up into the aorta. That might be another
I
way
know.
you could do it. Then you might be able to pull
We
down.
may have trouble crossing. Let's see how this behaves.
That's another option,
I
yeah.
didn't guess the right one.
Well,
So let's come down, we'll take a
what,
picture.
if,
not the biggest
any
thing in the
other
world.
suggestion? So we go either from brachial from above, or go from the left groin to see if we can move it out. The left groin option might not work because in the catheter we get it still stuck there. So this is what I did. I cut the hub of the catheter, the end of the catheter.
All right, so
Then
we have
I
the Viper
pulled
wire on the table.
My
Let's
short
go ahead and get
sheath
that
out.
and get the
Can you run
filter,
it
so
now,
we're all ready
please?
with that.
Then I put a 25
Please
cm
could drop one.
sheath over the catheter.
Yeah, let's get the
And
big
the
one. That
wire.
way we can.
And
it's pretty
push
small down there, but I think it's gonna
sheath
grow.
all the way up to where the kink was. I'm pushing the sheath.
about using that
What you do right now, you have the
Let's
the
wait,
wire
okay.
out, catheter over it.
Let's feel with the.
And the only thing I thought
just with
maybe
all
give
those
me a hard
curves and
time was
stuff.
entry to the artery. It was okay. I
Might
put
be
the
easier
sheath
to-
there, pushed against the catheter, then I pulled the catheter out. And here's the catheter. Okay, thank you. Very nice and easy.
think,
Okay, another great speaker. Really
Why don't we
pleasure,
get the?
David.
no,
Dr.
let's
Tom
get the,
Davis is going to talk about his way of
row three.
recanalizing, and I still cannot figure that
What's
one
the
out.
Yeah, let's do that.
Thank you,
Can we get
Amir.
America
I'm
Row
truly
3,
humbled being
300?
up here. I learned SFA and iliac intervention from Dr. Walker several years ago in a little place called Houma, Louisiana. And then I learned all about below-the-knee intervention over a bottle of scotch from a gentleman with cowboy boots and a cowboy hat on Sun Valley by the name of Amir Matarjame. So I am really, truly humbled, and I'm grateful for both of them. Anyways, what I'm going to be talking about is crossing CTOs with fluoroscopy using the Ocelot catheter.
So they're behind.
Here's my disclosures.
We have
So
about 5 minutes.
first off, if you look at peripheral artery intervention, there's limitations in terms of what we have. Certainly, you
I
cannot
think today's
appreciate
30.
vessel walls
Here's
with
what we should do.
angiography. You can only see the lumen and whatever lumen, the disease lumen that you have.
Go ahead and put the Viper down.
It masks tortuosity, as we've seen. Dr. Walker had that bent knee there. When you have the leg straight, you don't see the tortuosity of the vessels and where they dive down. And again, you have exposure to radiation. You have to track it and limit it. I've known some people who put their badges in their back pocket because they don't want to know how much radiation they're actually getting. And radiation itself is dangerous to us. Brain tumors among interventional cardiologists. Is this a cause for alarm? 4 new cases here in this reported article from 2 cities and review of the literature. And these tumors were on the left side where your head is going to be closest to that eye. So again, there is some indications that this radiation is dangerous to our health as physicians. If you look at the radiation exposure during percutaneous endovascular vascularizations, if you look at in the pelvis, thigh, below the knee, and multi-level, the ones where we're at in terms of the peripheral vascular is the greatest radiation exposure that we are getting as physicians. And again, when we do a lot of cases, especially complex cases, we are getting a significant amount of fluoroscopy. You can see the median dose area in grays per centimeter squared, and you can see the median fluoroscopy time in minutes in that degree, especially in multi-level disease. So this is not, it's a significant amount of radiation exposure that we all get. So the different type of modalities that we have to image these right now in real time, at least, in terms of when we're in the lab, are fluoroscopy, which is out of plane. As you can see, we have a total occlusion. We don't see the vessel itself. We see maybe calcification, but that's all we can see in terms of that, and we can see an origin and an exit point. We have in-plane IVUS, and you can see on the middle screen there picture where the IVUS does show a nice picture in terms of the vessel, but you can see that at 6 o'clock, that big halo there is actually a perivascular hematoma from a wire. This is where we've gone beyond the distal reconstitution.
No, that'll work fine.
And then you can see in-plane OCT, which is 10 times resolution, where you can see medial, adventitial, and internal and external elastic membranes. So this is the Ocelot catheter. What it has is a rotating tip with a light at the for optical coherence tomography at the tip, and it rotates in a clockwise and a counterclockwise fashion, so it looks like almost a radar scope when you're looking at the weather. And it's got a bent tip, so it deflects away from, you can deflect this again towards different areas of the vessel. The way it works is you have 2 outer markers and a middle marker. The middle marker is opposite of the direction of the tip, so if the tip is deflected this way, your outer marker is here. So you actually have, unlike ultrasound, directionality to this device. So you can actually put the middle marker, as you see on the right, at the layered structures. So you're seeing you're staying within the lumen, you're seeing medial adventitial layers there. You can actually put the middle marker there, and the distal tip of the catheter will point away from there, staying away from those structures. And again, here's the OCT images that you see as you're going down through the vessel. You'll see the layered, what we call layered structures, medial and adventitial layers, internal elastic membrane. And you see, as this is, we call cat ears out there, where that is where you're actually going through the layers, and it will release through that layered areas. And then you see the non-layered structures, which is going to be the diseased, focused areas.
I think we might need that one.
The key to this thing is it allows you to stay within the lumen without having to look at these structures. Some of the hardest things is looking at this, looking at the OCT images and looking at your, if you look at your fluoroscopy, you'll think that you're not in the right spot, but the OCT tells you you really truly are. And you can see here on the right side, the OCTs in the lumen, you can see at 9 o'clock some layered structures where you would put that device is you'd rotate the device so the middle marker would be against there, and you'd know the tip would be going against into the opposite direction.
Why don't we get a
the Connect 2 trial was 100 patients at 14 different sites, fairly good lesion lengths, 166 millimeters. The SFA and Popliteal, you can see 98% freedom from adverse events, as well as 97% crossing success. This is where it's got this.
The goal is not to.
So what I did was, when we first started doing this, we started looking at shutting the fluoroscopy off to see what we could do and if we can actually cross this. So this is something that we published, a little small series, and we had 15 patients with 16 lesions in the SFA and popliteal. And again, the mean lesion length was 18.6 centimeters. Our mean crossing time, as you can see, or actually I shouldn't say our crossing time, but our fluoroscopy time was 0.24 minutes. What we would do is we would just shut off the fluoroscopy. You can see on the fluoroscopy unit there the exact how many
I think this is
tenths of a minute of fluoroscopy that you're using. So you can see in these 16 cases, I used 5.88 minutes on average for just the diagnostic fluoroscopy, 14.88 minutes for therapeutic fluoroscopy, and 0.24 minutes for crossing fluoroscopy. If you look at the available data out there, the average crossing time fluoroscopy for crossing lesions is about 22 minutes. And think about it, you're going to have those that you cross very quickly. And I challenge any one of you who use loop wire technology to actually look at the fluoroscopy time that you're using to see exactly how much fluoro you're actually obtaining there. Now, this is since September 2013. We added some more cases here. I'm not sure how well this shows up out there, but what we did was we, again, looked prospectively at our cases, and we avoided purposely the cases that had significant calcium to them, because, again, with any crossing device, calcium is very, very difficult to get by those areas. It'll deflect things. So we avoided looking at those cases. We really looked at ones that had minimal calcium or no calcium, at least evident by fluoroscopy. And we looked at our 55 cases. We had 42 SFAs and 13 below the knees. And again, very similar to what I had before, mean lesion length of 169 millimeters. And you look at the mean fluoroscopy time, again, 0.3 minutes, which was very similar to my initial slide that I had with 0.24 minutes. Our mean crossing time was 6 minutes. And again, if you look at the therapeutic fluoroscopy time, 13.7 minutes. I think when you stay within a true lumen, which this gives you that aspect of, your intervention becomes a lot easier for you to do, no matter what you're going to do, whether it's being stenting, because you can adequately prep the vessel with that. If you're going to do atherectomy, you stay within the true lumen, have a much better chance of success. And I think even drug-coated balloons in the future might be better off truly within a true lumen. So my conclusions for this are dangers of fluoroscopy, again, are well documented with not only tumors, but eye problems and time in the lab spent, especially even to patients with radiation burns for some of these long procedures. OCT defines medial and adventitial structures, and where fluoroscopy cannot. You can't see the wall of the vessel. You can only see, again, when you're going down a total occlusion, an empty space. You see the proximal and distal cap only. So if you can actually see the inside of this vessel as you're going through it, I think it makes you a lot more confident and comfortable in where you're at.
All right.
OCT-guided crossing makes it possible to maintain a true lumen position, limit radiation exposure, I think both to staff and the patient, as I said again, staff including the physicians. And maintaining true lumen, as I said, enables the operator to use the widest array of modalities that you want to use, and I think much more successfully and quicker. I think that's where you can even reduce your therapeutic time where you're treating this patient. If you're really truly within the true lumen, you haven't extended the vessel from tears or perivascular hematomas as we see on ultrasounds. So I think you can be actually much more successful with actually treating these patients, the lesions as well too. Thank you.
We're not ready with a live case as yet.
What?
Tom.
Tom, we're ready.
Oh,
We're ready.
Jack,
Yeah, how you
can
doing?
you hear me?
I can hear you. Can you hear us?
Yes, very well. I have a very tough panel here for you, so you better be careful. Yeah. I have Dr. Walker here, Dr. Block, Dr. Lynn, Tom McNamara, and Mark Mewson. So we have a bunch of very, very expert, people here. So go ahead and see what we got.
I think we just opted for medical management. We have a, thanks again for involving us here at Alexian Brothers. Mark from AV is here to help us. And we have Sunil, we have Carrie, and we have Christine. Ready to go. It's this young gentleman's 90, and I say young because he swear he looks 70. He's in great shape, very active. And in 2005, we opened up a left common femoral lesion. It was quite calcified. We did Silverhawk back then, and that's been fine. In 2009, he developed a very calcified popliteal lesion that we used Diamondback on, and he's been doing fairly well. Last year, he was having some claudication. We did a duplex. His ABI was pretty low bad last year, 0.56 on the left, and he had a greater than 75% lesion in the popliteal. The common femoral was okay. But he got worse now. He's really can't walk very far at all, and he wanted to do something about it. And so what we did is, I was a little concerned that possibly the common femoral got worse because he was having quite significant symptoms, maybe at 2 levels. So why don't we show him the angios here, and we'll what we did. So this common femoral, you can turn the lights back down, has kind of an interesting lesion there. It doesn't look too bad, but I was worried that things were worse than this. We did IVUS it, and we got about maybe a 40-45% diameter stenosis by diameter. So we did do a quick pressure gradient. There was absolutely no pressure gradient across it. I think the reason is that the native vessels are big. They're like 8.5, 8.8. And we got almost 5 millimeter lumen within that lesion. So I don't think the common femoral is significant, but I welcome you guys' input. And down the leg, the rest of the femoral looks pretty good. He moved a little there, but I got it here. And here's the real problem, I believe. His popliteal is badly restenosed. As we played through, you can see it's probably quite underfilled distally there. But he does have 3-vessel runoff. Everything's, again, underfilled. He's kind of getting by on a lot of geniculate collaterals, and I think that's why he's having a rough time. So, what do you guys think?
I think we have to treat him.
Say, Jack, does he have a stenosis of the profunda as well?
I think he does. Let me go back to that for you there.
It didn't look like stenosis right into the deep femoral artery.
I don't show it very well, but it's coming off right underneath. I think there's an overlap. It didn't seem really involved on the IVUS. It seemed like everything was in the common femoral. So our thought was try to get across this, and we've done a debulking with calcium device before. So the question is, 5 years later, what do you expect? What do you think? Maybe Tom has a lot of IVUS experience here. But do you think we're going to find much calcium in the lumen, or do you think there's going to be all the? Actually, let me show you the calcium you can see. Is that all just out in the deep wall? Because you can see quite a bit there.
Well, let me ask our panel what they would do. Let's start with Mark.
Jack, could you clarify for us what his symptoms are? Does he have rest pain, or does he have claudication only?
He can have rest pain with 3-vessel runoff. He probably has claudication.
Well, no, he's got multi-level disease. He's got common femoral arterial disease, and he's got a popliteal occlusion. So if that lesion on top is significant, I would expect him to be in rest pain. That's why I'm asking the question, because if he has resting pain, fixing the proximal lesion may be sufficient to alleviate his symptoms. But if he's a claudicant, then the lesion at risk here, the most significant lesion, I think, is the popliteal lesion.
Yeah, he has very severe claudication. He can barely get across the room. and it hasn't gotten better. He's been trying to walk through it for the last year and not getting anywhere.
You haven't crossed that yet, that lesion as yet,
we would
okay.
start working on it while you're talking.
Okay. Go ahead.
This is Craig. I've got a couple comments on your points. To start with, I would treat the common femoral. I don't know why the IVUS doesn't show that, but that sure looks to me like it's more than 50%, at least by digital. And I think inflow treatment, whenever you've got an outflow issue, is part and parcel of the treatment. And obviously, the popliteal is your big area. This is a P2 segment. The question is, where's the calcium? You can answer very easily if you take that IVUS and bring it down. And I think that's useful. Yep. You know, we make a lot about IVUS. We make a lot about calcium. But no one's ever shown that removing calcium matters as long as you can cross and dilate and ultimately deliver therapy, perhaps with the one caveat of us not knowing what happens with drug elution therapy at that point. Calcium is a big problem. I don't want to suggest it's not. It makes it harder to cross. It makes it harder to create the initial channel and to dilate it. But we have never, ever, ever been able to show that if we simply remove it, we end up with a better long-term outcome. And so it's an interesting phenomenon. I know we get really hung up on it, but I would love to see that trial that at some point shows that if we take it out, it matters. And I just don't think we have that yet.
Tom?
Actually, I'd be inclined to, after traversing, which might not be easy, but I'm sure Jack will do it, I'd actually be inclined to start with the laser in hopes that some of that is a vaporizable material, because the calcium, if it's due primarily to eccentric and where she had intraluminal calcified plaque, that's a much harder problem. And I think the laser would help clarify whether that is or is not really what you have to ultimately deal with.
Hi, this is Tom Davis. Amir neglected to introduce me.
Hi, Tom.
I think he's mad at me.
Oh,
anyway,
no.
Anyways, you know, I think the problem with treatment here is that you really won't know what you can do till you cross this, because it'll depend upon if you're subadventitial, how far you've extended this with wiring. So I think this is actually one of those spots, and I'm a big proponent of crossing devices, but I think this is actually one of those spots where crossing devices are very good, because this is one of those places where, as Craig had pointed before, there is a mismatch between the vessel size proximally and distally. And if you're dissecting down with a wire, it's very hard to stay within a lumen, and you tend to extend this. And I don't think you want to extend this down too far into that P3 segment. So I think this is one of those places where a crossing device is very, very beneficial.
And which one
I think
do you advise?
that's a possibility. We do kind of see a small lumen. It's quite serpiginous here, but we're going to see if we can traverse it. Do you have a torquer? Keeps wanting to go the wrong way. So yeah, our plan was if we could get across this cleanly, we really did want to IVUS it to get an idea of what's left and what it looks like.
Craig, you do a lot of pedal work, so you think it's access to this lesion is easier from pedal approach rather than integrate approach?
Yeah, I do think it would be easier. I still would always try, as Jack is doing, from above. But I think if you can't cross this from above, pedal will do it. I would like, certainly a roadmap here. I think that's very helpful, some of the CTO wires that we use. And actually, the device Tom just talked on, I think, would be very interesting here, because you truly can stay intraluminal. The problem here with perforations is not typically the popliteal itself, but you get into many of these small branches coming off, and you perforate there. And that's potentially a problem. But I think, Jack looks like he's making some nice headway here. Jack, what are you using to cross?
I was going to ask him something.
We have an 018 CXI catheter. And we have, right now we have America-Bro 3. And I mainly use America-Bro to get a tip. I don't know if you can kind of see in the picture. It does make a quick, what's that, the second or third turn is tight. And then I think I may switch out back to our gold tip end to see if we can slither down the rest of this without getting somewhere bad.
What's the size of the wire? Is it 018?
The gold tip M is 018. I have to say it's pretty firm blockage. I don't know if that's just really old restenosis or true calcification.
I forgot to angio. Do you have a good segment of popliteal artery below the knee?
Yeah. It went down the wrong one.
You reconstitute prior to the
It's
trifurcation.
small.
Yeah, it's diseased.
Yeah. Let's get the torque. We'll try once again. But
You know, if I were
we're
using a
gonna do
wire
that.
here, one of the wires I really like with Roadmap is this Victory series of wires that's recently come out. I think they're very torqueable. You can get nice pressure on the lesion, and they've got nice tactile feedback. For me, crossing a CTO is as much about looking at the wire and making sure it still is moving and never bound down, as well as how it feels upon withdrawal. One of the things when I went to Japan and worked with a lot of the guys there doing peripheral
Let's go
work,
back to that one, 'cause
I made
got a
them show
better
me some
curve
of their
on that one.
coronary technique. And a big part of what the Japanese do is they pull back on the wire every now and then. If the wire feels bound as you pull it back, you're probably in the wrong space. That's a great tip that really has helped me a lot.
Yeah, that's exactly what this felt like a second ago.
Any of you would use a glide wire down there? 035? Oh, right. In this case, I said, would you, any of you on the panel, would consider using 035 glide wire to wiggle through that, occlusion?
Yeah, I would try it, but it wouldn't be my first wire. It'd be my last shot that I would try from an antegrade approach. But I don't think there's anything wrong with using it as long as you do not extend a dissection. How about you, Amir? Would you use it?
I probably use glide wire. I always do. That's my first wire that I use, and I don't care how small the artery is. I don't know if that's because I have got so used to it that I can work with it a lot easier than with other wire and catheter combination. But of course, I use a supporting catheter with it. As soon as I advance my wire to a certain extent, and I advance my catheter and gradually work my way through the occlusion.
Do you use the extra support or the soft?
Sorry, I didn't get.
Do you use the extra support glide wire or just the soft?
No. I at this point I use soft. Yeah.
There's another interesting catheter, and I think would work for this as well too for this spot. I think it's called Multicross. They made it for the coronaries, but it's a nitinol sleeve, almost like stent, that can be resheathed. It goes into the proximal to the cap, so it gives you a lot of support, but it's got 3 wire ports to it. And so you can use your 014, 018 wires in there, and very stiff wires. I certainly like a lot of the Asahi different type wires for this. And the nice thing about it is, as you go down through that vessel, if you go into a subadventitial space, you can leave your wire there. And you can go through another spot, through one of the other 2 ports to see if you, to get in a different spot, so you're not constantly going into the same dissection plane that you just created. So, which gives support, and it's another unique way of trying to wire these.
Whisper. See if we can get a whisper to sneak around that corner. Yeah. So we're still, the issue here is, do we try to take this little lumen, or do we ignore it? I still like to try a little harder to get down the lumen, even though we're having trouble making this turn. We're going to try a little whisper wire, see if we can get something we can steer just a little bit more, but also kind of slide down there. Because I do think we have a route, the little lumen there, but I guess if we didn't think the route was there, I would probably go more towards a Wildcat or an Ocelot to kind of, because it's straight and we can probably get through that.
Jack, does your roadmap have does it show the beginning of the CTO as well as the reconstitution point? I can't see that from here looking at the image.
Sorry,
or do you just have that distal part?
So it's on multiple levels, but there's the distal. Can you see that?
I see that fine. I like to have all of that up when I'm using my wire, because it just tells me if I'm going in the right basic plane.
Absolutely.
Jack, is it better for you if we go and have a talk and come back and see?
Yeah, if you want, I would like you to keep coming back so we can show you what's going on.
Yeah, we'll come back to you. I thought maybe it would be even easier on you, whether we don't watch you.
That would be wonderful. We'll be right here.
Okay, Jack, we'll give one talk and we'll come back again.
All right.
Okay. Well, the next talk is going to be by Dr. Alan Block, and he's going to talk about the entire team management.
Good morning. So I'm tasked with team approach, and I'm going to show you 3 cases, and I'm going to simply give you the thought process behind it. So I'm just going to tell you some things. The first thing I want to start off with, which I always do, the first thing before I become this incredible physician I like to pretend I am, I like to assess the patient's family, because these are cases where the patient may sometimes be better with an amputation. As hard as that may be to say, it can be true. And the first thing is family support. So the first thing I assess with my patients is that. And then the team is, like you say, it's for me, family doctor, internal medicine, cardiology, vascular surgery, any interventionalist type deal that wants to be involved with this. But the idea is, this is how we do it. And the first thing before I do anything, I get a vascular workup, not an ABI, because although a lot of times I'm fooled by a pulse, the truth is I want to know if they have functioning. I want to know if they have functioning vascularity, but not just arterial, but venous as well, because we call it an exit strategy. And I've actually named it that in my office. I go up to my office manager, I say, I need an exit strategy on this. That means complete workup, and I get it done. So very, very simply, here's the 3 things that I always think of in the first thing. First of all, I know they have to get blood flow down there. Most of these patients in the hospital, they have a PICC line. And the problem with a PICC line is it gets the medicine into the blood. But if the blood's not being sent to the feet, I can't do anything. I can't get rid of the infection. I can't treat the patient like I need. So there's 3 things I do immediately. One is I order an MRI. And the MRI I get, I call it infectious disease, obviously, but I do something where I swab the wound. Now, swabbing the wound sounds really simple, but it's through something called target-enriched multiplexing polymerase chain reaction. That is DNA testing of the virus or the bacteria that lives in there. So these patients usually on antibiotics when I see them, and a lot of times the antibiotic will sequel or squash the footprint of the bacteria. What this does is if there's DNA present, and there has to be no matter if there's antibiotic or what, it tells you what you're dealing with. So I get the patient on an antibiotic they need, because the first thing, we have to eradicate the infection. So the first thing is restore the flow. Second thing is I'm taking cultures all the time. The MRI comes back. The MRI is not the definitive for us to tell us if the patient has osteomyelitis, and a bone biopsy. So I do all 3 of these very, very simply, my first thing, as well as that vascular workup. I'm going to start very simply by showing you a case that happened to me. This is a 16-year-old female. She came up from Georgia. She had a bunionectomy done, and she developed osteomyelitis, and she did nothing about it. I'm not going to read through this because of time, but basically what happened, by the time she came to me, she had such infected bone, we had nothing to do, and she was offered amputation by other physicians, made it somehow to my office. What we did is we took out the infected first metatarsal bone. This is the first time in history it was done, and I know it was scary because the residents would not put their name on the op report. That's the first sign that you're going into uncharted territory, right? But the point is, we took out the bone. This is fresh frozen graft. I measured it, I did everything possible, and I had bone delivered from a cadaver, and you can see the first metatarsal. Now, the interesting part about this, she had venous and she had arterial congestion. It turned out that she had a clot in there, and they had to go in and clean it out before we could do anything else, again, to deliver the antibiotic. For 6 weeks, I left her on antibiotics. I kept swabbing her and taking tissue samples. I finally took this first metatarsal, and I locked it from her cuneiforms all the way up to her great toe, and we put this together. Now, the interesting part about this is you can see the tissue here well perfused, and this is at 10 weeks. I'm reimplanting a metatarsal in her. And you can see the metal and the software, the hardware we're putting in there very, very simply. And I'm going to skip through that again. But the bottom line is what she ended up with is this is what she looked like afterwards. Now, she was going to keep that. She was a track runner, which she probably would never do again. This is her post-op, as you can see, and I lost her to follow, but at 3 months, she walked back in, walking on it when I told her she couldn't put weight on that foot for a year. So this is that kind of thing we can do as a team approach, and here she is. Not the prettiest, but that's after multiple surgeries and infection. I'm going to skip to the next case here, and this is that pylon fracture that comes in. This guy has had, kidney transplant. You can see here, pancreas. He's had a 10-month status. He's status post a pylon fracture where he lived in West Virginia. They were simply putting him in a cast. This is how he walks into me, because at 10 months they said to him, if you can't walk on this, have it amputated. Now, he's a very sick individual, and he has a phenomenal support staff and his wife and his family, and he didn't want his leg amputated, but he's too sick to be intervened on very simply by the bypass. Severe infection that we control very simply by they had an intervention done on him. I'm just going to share this progresses. So it started by antibiotics getting to the place. And the thing is, I have 15 cases now where the patient has osteomyelitis in their foot, but instead of cutting the foot off or the leg off, we're treating it, because you can live with chronic osteo just like you can in your back, because it turns out if you look at the long-term sequelae of leaving the foot on as opposed to taking it off, the patient will do better with having the foot intact. So you're just following here, and all I did was get antibiotic restored, get flow restored, get an antibiotic to the area, open it up so I could drain it, but all I did, very simply, was put him in an external fixator and bring him out to length. The body followed its own periosteum and rebuilt, as you can see here, rebuilt this whole about 8-centimeter piece of bone, regenerated, okay? And you can just see following through. Now, I'm still amazed when I see this case very simply, and you can see how well he's doing. This is 8 months in an external fixator, which is not a pleasant thing for anybody, but he was willing to keep his leg, and you can see the body started to over-regenerate because it had blood flow. And if you restore blood flow to cells that have been starving for blood, they will react, and they will actually overreact like you see here. This is him towards the end. I finally took this off, and you can see not a pretty ankle, but he's very, very neuropathic. Unfortunately, 2 years after doing this, he lost his leg because it got an infection on the other leg, and they kept him in a hospital bed, and he ended up losing that leg, this leg, because the infection passed through it. And again, one of those things I tell him is you've got to go where you got to come back to me. You got to follow me. But this is the one that's really important, because after that first case where I very simply put in the first metatarsal, we see a lot of calcaneal osteomyelitis, the heel bone getting infected. Again, this is a 350-pound male. You can see the infection here, would not let his leg be taken off. And the unfortunate part, when you take a look at this leg here, you can see here what he's coming in with. You can see that the toe, the distal part, and he's slated for amputation. He came in to see me. This is just before surgery. So you can see here, and all we've done is intervention, antibiotics for 10 weeks, right? We cleaned up that wound. He's actually doing well. The odor's gone. The drainage is gone. He's showing, I got to tell you, he's osteomyelitic at this point, but it's been 10 weeks, and he's cleaned up, and he showed us multiple swabs of not having infection. But this is a train wreck. And you can see here, he had surgery years before where they put a rod up his foot, and you can see the rod, his foot completely exploded due to the infection. Again, he's 350 pounds, and he wants to go back to work. And I'm going to run through this, again, just in lieu of time. Here's what we did. Got rid of the infection. So once we opened it up, once I had the infection going under control, I put antibiotic beads in it, which you see me doing here. I leave the beads in and for about 2 or 3 or 4 weeks or 5, and I simply take them out. What I was then able to do, because I started to get a little bit braver in what I was doing, is this right here is a fresh frozen tuber. It's the back of the calcaneus. I took a cadaver, we harvested it, fresh frozen, sent it to us, disease-free, and I swabbed these, by the way, put this in, would not put hardware in here on this patient just because of him. Put this back in so you can see what we've done here. We've restored the calcaneus because he wants to walk, and at 350 pounds, he's not going to do well without a heel bone. Again, this is, you can see how good the tissue at this point looks. I'm getting very, very brave at this point. Because why? I've got a support team behind me. I have infectious disease, I have vascular, I have interventional cardiology, I have internal medicine, and I have a team working with me. We have infectious disease. We're starting to get a stride, is what we're essentially looking at. So again, put him back into an external fixator now. Now, what I did is I put one screw through him, and that was to hold the cuboid and the calcaneus and that tuber that I have just put in. But watch what his body did to this. Now, the calcaneus, if you don't know, is the most vascular bone in the body, and this is him following up. And if you watch very simply here, you can see that this area is going to disappear, and you can just watch it happen. Again, this is 8 months. 8 months of having to wear this, but you can see that this is starting to go away. And this is a gentleman, as you can see him, about 3 weeks post-op. So he's a big guy, and here he is at 1 year. He comes in every year to check this. Now, the point of the team approach is this: the amazing work that you're able to do, the fact that you've come up with pedal sticks and hybridizations of these other procedures are allowing us to succeed in places we never thought we could. So the whole idea, very simply, is this, is if you know what you're treating, you get a good team together, we can work miracles, at least what I think are miracles, because 10 years ago, I couldn't have saved this life. I couldn't have done anything. But again, as a team, if we work together, we can do amazing things. I appreciate your time.
Thank you. We're going back to Jack. And, oh, here we are. Jack, we're back.
Yeah. Well, we haven't gained a whole lot. We decided, I think the two best options now are to either go from above with a CTO device or stick him in the foot. I think we're going to go ahead and try Wildcat from above. But knowing that we definitely got at least two good options from below, that if we have any issues from above, there's no reason to push it. I think we could wire this from below a lot easier. What do you guys think?
Well, I personally would rather go from below. You can, of course, try your device. Any of them you have in your lab and you know how to use them. But I think at this point, probably a retrograde transpopliteal would be a better choice. At least if I was doing the case right now, I would go transpopliteal.
So Amir, just in general, I agree with your comment with the 035 glide wire, but in general, when you approach a popliteal lesion, do you start with 035 or do you start with 038? Because I hear a lot of different people here that do different things. Do you think it's important?
No, I personally use Mark 035, and in a tighter lesion like that, I use a crosscat catheter by Cook. It has the tip of it is a little bit narrower than crosscat, quick cross. And so I'll try that, first, and if it didn't work, just like the problem that Jack has right now, then I'll probably approach him in a retrograde popliteal approach.
In looking at how much calcium I see there, I would approach this with an 18 thousandths, 30-gram tip, sharp angle, Victory 18 wire. You see how much calcium there is right there? I would come off the roadmap, and I would use my calcium as my roadmap. So and I think you could potentially get through this. This is densely calcified. Okay. The subtracted shots didn't show it before, but you can see it now. This is profoundly calcified. And so I would just use the calcium and try to forget, because I think some of these channels we're seeing may be collateral channels, and I would try to follow this calcific roadmap.
So you start 018. You just would start 018. You wouldn't even go 035 first.
I would ultimately go to 035 if it didn't pass, but I would start with a very sharp angle, 18 thousandths Victory 30-gram tip with a 18 thousandths support catheter. I think it will get you through this, and I think with this much calcium, you can potentially see where to steer. They've been through here before. More likely than not, there's a stricture there, from the healing, and I think you'll get through it.
Jack,
So
is there any way you can get us a lateral view or off-angle view? Because it looks like that may be a geniculate branch coming there, and you may be actually getting into that, because as I'm watching your Wildcat go down there, it almost looks like it's going lateral to that calcium. And so I'm wondering if that's actually a branch that you're getting into. So maybe you can take a lateral view for us, or LEO-REO view, just to see if we can get that off.
I was thinking the same thing, because it completely follows without any effort past our calcium. So I was going to go back and look when we had a little better picture. Hold on a second. This one. Because it seems to see that little thing there, but it doesn't even follow that. It seems to be going outside in some place we don't want to be. So I don't know. I'm thinking more retrograde from the foot. This thing, if we can do that, though, let's take another picture. Let me get this out of the way a little bit. Let me get the calcium back in there. Hold on a second. Yeah, that little, I don't think it was a actual branch. But either way, it doesn't seem to be following the route we want.
I think if you direct your catheter, because your catheter seems to be going lateral, I think if you direct it more medially there, it looks like that may be your channel, because I still think that there's branches off there that and that's the horrible part of doing a case like this. You have so many small little branches that come off in there, and you get your catheter in there, and if you keep on pushing there, you can cause just a huge perforation and very difficult to control at that point in time. But that's got a little bit of a tip on her. If you even put an 018 wire in there and just try to direct it, and I think a little bit more medially there.
I haven't actually rotated anything. It's just interesting how it went there. Let's go back to AEP.
Jack, we're going to have another talk and give you some time, and
I think we're going to
come back to you.
Yeah, we're going to prep the foot and work our way up.
Yeah.
Let's do this.
Okay.
Let's take this out.
Okay, we'll see you later. Thank you.
All right.
Well, our next speakers is a topic that I couldn't wait until I hear what Dr. Lin has to say, and that is the treatment of the long segment SFA occlusion, a 5-year comparison of bypass surgery and viable stent graft.
Thank you so much. I want to thank the organizing committee for inviting me to this meeting. So treatment of SFA with endovascular intervention is something that many of you probably face on a daily routine in your practice. And I will submit to you that successful treatment of SFA intervention or lesions is not an easy task, in part because this vessel is very unique. There's no other vessels in the body compared to SFA that face so many geometric or mechanical force. And specifically, there are probably up to 6, 7 different mechanical forces that this vessel face on a regular basis. As an example, many of you are sitting here in this chair. When you sit from a standing down to a sitting position, you create a contraction force on your vessel. If you were to sit here and cross your leg, that creates a flexion or torsion force on your vessels. And if you were to put your laptop or your backpack on your thigh, that creates a compression force. With different geometric forces acting on these vessels, this creates a particular challenge. And a lot of the problem faced in SFA stenting, the credit actually goes to Dr. Walker, who many years ago identified the particular problem relating to SFA stenting. If you were to put a stent in the SFA popliteal junction and simply flex the knee from 20 degrees to 90 degrees, you will see a very appreciable compression or kinking. And many of you probably took a flight coming to Chicago. Imagine if you sit in an airplane with a knee bent in a 90-degree position with a stent in the artery, merely a 10 minutes compression can potentially cause thrombosis of that popliteal or SFA stenting. In addition, with this type of flexion problem, Dr. Walker has alluded out many years ago in his publication that SFA stent fracture is a unique problem in this particular locations. When you put a stent in that location, it has been estimated that you probably flex your knee up to 2,000 times a day. You time that by 7 days a week, 30 days a month, and 365 days. This will result in fracture. Besides the metal fracture being a problem, when you place a metal in the SFA, what you're seeing here is a particular type of phenomenon in which the blood flow coming in contact with the luminal surface of the SFA, which has a lot of atheromatous plaque. This creates a particular problem called in-stent restenosis, meaning that this stimulates further ingrowth of the intima due to smooth muscle cell proliferation. Over time, this creates a very diffuse narrowing, eventually lead to occlusion. With these type of problems, over the last several years, engineers, researchers, and physicians have gotten together trying to come up with a better solution. And this has resulted in a particularly better device. Now, this is a histological sample of what's so-called in-stent stenosis. This is largely related to the smooth muscle cell proliferation, relating to a problem when you put a better metal stent in the SFA. Now, with that said, a better solution has been born, and this is related to the development of a Viabond, which is a covered stent graft, and more recently, now you can get the Viabond with a heparin coated. This is a particular device that's made of nitinol strut with an inner lining using a material called PTFE, and this is the same material that surgeons have been using for fempop bypass graft for the last 50 years. The same material you're using for the inner luminal lining. And the device comes with various lengths. More importantly, nowadays, a 25-centimeter device is available, which is ideally suited for long SFA lesions. It has diameter ranging from 5 to 13 millimeters. Now, device is highly flexible. It can conform to a very tortuous vessels. If you were to take a device that's a 15 centimeter in length and compress it by up to 40%, shown here, you will see that device maintain its structural integrity without any deformity. And over 3,000 publications, a stent has been reported in the publications. No Viabond stent fracture has been noted in the placement of SFA. Now, the importance of compression and flexion is also highlighted in the in vitro studies. If you would take a device that's measuring, for example, 10 centimeters in length and do a 25% longitudinal compression, and you do the same studies in a very simple benchtop studies compared to other comparable stents, you will see that this particular device can maintain its compression force and maintaining a similar longitudinal structure without any deformity of the device. Similarly, with a flexion test, as Dr. Walker has also slightly alluded to earlier, if you were to take a device and bend it in 180 degrees, maintaining the outer to outer edge with 3 centimeter in length, this device can maintain its conformity very well compared to other devices. So with that said, this device also has additional benefits because in contrast to a bare metal stent, when you put a bare metal stent in the SFA, the continual interaction between the blood to the atheromatous plaque can lead to this intimal lining development due to smooth muscle cell proliferation. By placing a cover stent, you created a barrier allowing a PTFE to separate the blood from contacting the atheromatous plaque. And over time, you still get a continual blood flow, in part because of the blood barrier provided by the PTFE lining. And then from a histological standpoint, with a long-term follow-up finding, if you were to look at a histological study up to 3-4 years later, the PTFE lining remained a blood-bearing barrier and separating the blood from contacting the atheromatous plaque, thereby minimizing the smooth muscle cell proliferation. There has been a lot of literature shown a lot of studies shown in literature with looking at the Viabond in the treatment of long lesions in SFA, and by and large, the results are excellent. 1-year patency range between 80 to 90%. Specifically, I want to point out to you 2 studies. One is from our group, published several years ago by my partner, Dr. Kujias, and more recently, a prospective randomized study has also been published, which I will highlight with you some of the findings. This study came from our group several years ago, in which we look at specifically patients with a long SFA occlusion. We define SFA occlusion by 15 centimeter occlusion, and we look at comparatively between Viabond versus balloon angioplasty. And not surprisingly, Viabond stent, which is a covered stent graft, compared to PTA, has a significant better results at 12 months. More recently, there is a randomized prospective study looking at Viabahn compared to surgical bypass. And this is one of the few randomized prospective studies that has been comparing between the endovascular treatment modality versus surgical bypass. This is a group come from Dallas, a Baylor group from Dallas, that we randomized 50 patients comparing PTFE bypass, which is considered a surgical standard of care, versus percutaneous Viabahn, which is covers stent graft and SFA lesions. And an initial study looked at 12 months duplex ultrasound finding. In 1 year finding, they show comparable results in this prospective randomized study between this two patient cohort. And again, with a primary patency, these two treatment outcome has an identical patency at that time point. More recently, they also follow up with a full-year data comparing the same cohort, again, with a prospective randomized comparison between the FEMPOP bypass with a Viabahn stent grafting. There are 50 patients in each arm. Again, 50 patients undergoing PTFE bypass compared to a similar number cohort undergoing Viabahn stent graft. And an average treatment length of 25 centimeters. And in this particular study, with a 4-year outcome, they show that there's similar patency rate between the Viabahn group compared to bypass, with a 4-year outcome roughly at 50%. With a secondary patency rate at 4 years, this two group between the surgical bypass and a Viabahn stent placement also has a similar outcome. And specifically, when they look at other variables, such as the diameter of the stent graft, interestingly enough, they know that there's a statistical trend toward favorable or better outcome when you place a 6 to 7 millimeter Viabahn compared to 5 millimeter device. So in conclusion, this device is particularly flexible, thereby it can conform to the tortuous nature of the SFA, and clinical evidence show that this device does behave much better with favorable outcome compared to PTA or bare metal stents. And this particular PTFE lining does act as a mechanical barriers so that it minimizes smooth muscle cell proliferation and reduce the instant stenosis that we see commonly in bare metal stent. And lastly, what I share with you is a prospective randomized study that did indeed compare to the PTFE versus FEMPOP, and it shows that these two treatment outcome has its comparable outcome results. And again, the study also showed that there's a statistical trend toward a favorable patency when you place a 6 to 7 millimeter Viabahn compared to a 5 millimeter device. Thank you so much for your attention.
We can break for the lunch. So lunch is being served outside, and please go and help yourself.